All right. Thank you, Dr. Algarni, for that introduction. And moving right along, because we have a full afternoon, I'm going to talk briefly about endometrial cancer, a little bit, no conflicts to this, a little bit about some of the classification and predisposing factors for endometrial cancer, but then to get to kind of a couple more contemporary issues regarding surgical staging and some available surgical approaches, then a little bit of discussion about treatment options for higher-risk histologic types and for advanced and metastatic disease. So, in the United States, uterine cancer is the fourth most common malignancy in women, but the seventh most common cause of malignant deaths. Represents about 56% of new cases of gynecologic cancer and is responsible for about a third of the GYN cancer deaths. And when we think about uterine neoplasia, we generally think about two main categories of tumors here, sarcomas, which Dr. Herzog will eloquently discuss later on this afternoon, and then adenocarcinomas, which we generally divide into sporadic and inherited types. But among the adenocarcinomas, there are type 1 and type 2 tumors. Type 1 are more common, tend to be associated with excess estrogen exposure, are usually have hyperplasia as a premalignant phenotype, present generally in younger age patients, tend to be low grade in endometrioid and histology with a better prognosis. Type 2 endometrial cancers, on the other hand, are generally not associated with estrogen exposure, more likely to occur in older women in the setting of atrophy, more likely to be high-grade tumors. Serous and clear cell histologies are more common, generally are associated with a worse prognosis. And you can see that in this slide here, this is incidence of cases and associated deaths by grade and high-risk histologic type. So the majority of cases are going to be these low-grade type 1 cancers, whereas the majority of deaths are going to be made up of the type 3 tumors. Classic risk factors that we associate with endometrial cancer are generally associated with cumulative estrogen exposure, age, history of infertility, menstrual irregularities that all decrease the relative exposure to progesterone and increase the relative exposure to estrogen, tamoxifen exposure, less common things like estrogen-producing tumors, all increase risk. Obesity is certainly a known risk factor, causative factor thought to be peripheral estrogen, or conversion to peripheral estrogen-like compounds, although there may be other factors that we're as yet unfamiliar with. Certainly protective factors include the use of oral contraceptive pills, any prior pregnancy or multiple pregnancies, late menarche, cigarette smoking. So just briefly to review, if an endometrial biopsy shows complex atypical hyperplasia, what's the risk that an underlying endometrial cancer is present? And this data was very novel about 10 years ago that in the GOG 167 trial that included a pre-op diagnosis of complex atypical hyperplasia. It wasn't really the endpoint they were looking for, but more than 40% of patients were found to have carcinoma on final histology or in final pathology, and this was much higher than initially suspected, but studies since then have confirmed that anywhere from 40 to 60% of patients with complex atypical hyperplasia on endometrial biopsy are found to have at least an early endometrial cancer. So just, I kind of only show staging here to emphasize what's the importance of staging. Well, certainly in these Kaplan-Meier curves here, you can see that the proportion of patients surviving is intimately linked with the stage of the cancer, whether it's surgically determined or clinically determined. But the surgical determination, i.e. assessment of lymph nodes in appropriate patients, leads to a much better ability to predict outcomes in these patients, and is why surgical staging is still a tenet of management of endometrial cancer. So this staging generally consists of a kind of standard procedure, removing the uterus, tubes, and ovaries, assessment of the lymph nodes, But whether lymphadenectomy versus sentinel lymph node dissection versus our patients, low enough risk that lymph nodes are not required is a ongoing area of question, subsequent research, and one of the things that we're going to talk about. Minimally invasive surgery has certainly become the standard for managing endometrial cancer in the United States, and whether that's done laparoscopically or robotically is dependent on the surgeon, the institution, and the available resources. Adjuvant therapy follows the results of the surgical findings, and we'll talk briefly about that as well. So who without a question should undergo surgical staging? Well, certainly anyone with a grade 2 or higher lesion, deep myometrial invasion, extension into the cervix, any evidence of true high-risk disease like extra-uterine spread or high-risk histologic types obviously involve lymph nodes. What about grade 1 tumors? Well, there have been several studies kind of looking at a pre-op endometrial biopsy showing a grade 1 tumor and what's the relative risk that you're going to find additional information after hysterectomy, i.e. a higher grade tumor, not a stage 1 tumor, evidence of extra-uterine disease. And in cumulative, there's about a third of patients who are going to be found to have higher risk histology or higher risk pathologic findings that if in retrospect you knew were there, you would like to have staged them. So we do generally, at our institution, do still favor staging grade 1 tumors. Other advantages to staging, identifying occult disease, providing a more rational approach or evidence-based approach to postoperative management. You may eliminate the need for pelvic radiation therapy by knowing what the status is of the lymph nodes. The potential therapeutic benefit is certainly debatable. There aren't really any cancers we can argue that removing occult metastatic disease improves survival, but there are some retrospective studies speaking to this. Disadvantages include longer operative time, increased blood loss, although the relative difference is fairly minimal. Certainly increased risk of lymphedema and associated complications from removing lymph nodes. So just briefly to review, minimally invasive staging was assessed comprehensively by the GOG in the LAP2 study. More than 2,600 women with early endometrial cancer were randomized to laparoscopy versus laparotomy with appropriate endpoints, both for survival and quality of life and complications. The conversion rate was acceptable, certainly much lower now that this is a technique that's done more frequently. All the benefits you'd associate with laparoscopy were there, less hospital stay, less pain afterwards, shorter, faster return to work. And for the first 6 months, these patients certainly had improved quality of life. Now, in the United States, laparoscopy certainly is still performed at many centers for the staging of endometrial cancer, but the development of robotic technology, at least in institutions where that's available, has certainly become a standard for managing these patients. The computer integration, the ability to have better visualization and control of the instruments, certainly in certain patient types, i.e. morbidly obese patients with endometrial cancer, has some significant advantages. So when I was at my previous institution, Ohio State, we did a number of kind of early research studies looking at factors related to robotic surgery and what might have been some of the advantages there. So we looked at the first 97 patients with endometrial cancer that we operated on there. About 9% required conversion. The majority were able to have complete lymph node dissection. We were a little bit selective in the beginning, meaning the average BMI was 34 rather than kind of what you'll see later on, and the majority of these patients, robotic surgical staging for endometrial cancer was feasible. Slight improvement in terms of kind of room time, conversion, average BMI to similar patients that we'd operated on at the time laparoscopically. But what about obesity? And the slide says America is facing an epidemic of obesity, and the other guy says it's widespread. It certainly is very widespread in the United States. But we knew that the conversion rate was higher in our morbidly obese patients, and it doesn't look like my headings, but this is BMI, and then this is conversion rate. And when we looked at 74 patients with a increased BMI, you can see that the conversion rate certainly went up. And so one way to look at this would be to say, well, you had a 50% chance of converting in a patient with a BMI of 55. But by the same token, you could say 52% of these patients had successful staging done minimally invasively and significant improvement in their postoperative outcomes. And this again were the initial patients that we did. By the time that I left OSU, our conversion rate in the patients who were BMI 50 and higher was more like 10%. So Sentinel lymph node assessment has received a lot of attention for endometrial cancer in the last few years. Initially without a whole lot of data. I think part of this is because there's a fair number of people who believe that grade 1 early stage endometrial cancer probably doesn't need lymph nodes, so it was a safe patient population to assess with Sentinel lymph node protocols. But as this has been done more frequently, we're starting to get more information, and I'm going to present some of that here. So Sentinel lymph nodes, for those of you who are not familiar, are lymph nodes with a direct lymphatic connection to the primary tumor, and therefore most likely to receive a metastatic cell from the primary tumor. The rationale for identifying Sentinel lymph nodes is to obviate the need for a complete lymphadenectomy. And technically this is performed by injection of either blue dye or indocyanine green, which is a dye that's detected by a near-infrared camera, or radiolabeled technetium. So there's lots of recent studies looking at small cohorts of endometrial cancer patients staged with Sentinel nodes, and I present one of them here as an example. So this is a recent study from Sweden, 188 women over a 2-year period who underwent robotic staging using indocyanine green. 79 of these had Sentinel lymph nodes only, and the majority of these were patients who were low risk, and 111 had a complete lymphadenectomy. All those were high risk, and they were mainly looking at the assessing the accuracy or detection rate for Sentinel lymph nodes, and they did find that certainly this was feasible and with a high detection rate. Looking again at low grade, low risk patients, this is a study from Johns Hopkins that looked at 113 consecutive patients with low risk endometrial cancer. And what they really wanted to demonstrate was that they, the current NCCN algorithm for Sentinel lymph node mapping essentially says that you do the hysterectomy and then you try to identify the lymph nodes on both sides. And if you're not able to identify Sentinel lymph nodes, you default to a complete lymphadenectomy. Well, the investigators at Johns Hopkins thought they could introduce another step in the patients who didn't have successful unilateral mapping on one side of their pelvis. They performed an intraoperative frozen section of the uterus, and if no high-risk features were identified, they didn't do a lymph node dissection on that side. Certainly this was feasible with good outcomes in the patient, in the relatively small series, but introduced another wrinkle. Again, trying to obviate the need for a complete lymphadenectomy and or intraoperative stratification of patients who may be high risk. There are a couple studies looking at not low-risk patients. So this is a group of patients that were determined to be high-grade, high-risk. Investigators at Memorial Sloan Kettering took a historical cohort from the Mayo Clinic that had been published, 210 patients who had complete lymphadenectomy, pelvic and periaortic, not necessarily a high-risk cohort, but all comers, and then looked at a group of 202 patients who were assessed by Sentinel lymph node assessment at Sloan Kettering over a period of time from 2006 to 2013. And so in the patients who they identified an intermediate risk, a number of them were found to have stage 3C disease, i.e. positive lymph nodes. And this was 28% in the historical cohort from the Mayo Clinic and 35% in the group who had Sentinel lymph node assessment. The p-value here wasn't significant. It was, but they're at least they're in the same ballpark in terms of the number of positive patients with positive lymph nodes they're identifying. In terms of the patients who were truly high risk, again, it was also similar. And although periaortic node assessment was more frequent in the group of patients who had a complete lymphadenectomy, the kind of risk stratification in terms of what adjuvant therapy was recommended for most patients was not different. And they used this preliminary data to argue that sentinel lymph nodes may have utility in the assessment of all patients with endometrial cancer, not just ones who are low risk. Obviously, this merits kind of further study. So what do we do for postoperative treatment? Well, there are a number of uterine risk factors that we use to gauge the likelihood that a patient may recur and use that information to decide whether adjuvant treatment is necessary to decrease that. That includes the grade of the tumor, whether the presence of deep myometrial invasion is present, whether the cervix is involved, and whether there's involvement of the lymphovascular spaces. And each of these leads to a kind of increased risk of recurrence and helps us to identify what early stage patients may benefit from further study. So there are a few studies, classic studies, speaking as the PORTEC trial looked at intermediate risk patients who were not staged by lymph nodes, 700 patients in total that were randomized to postoperative radiation versus observation. And certainly the group who received radiation therapy had a lower risk of local recurrence, similar 5-year survival, similar overall survival, and a higher risk of complications. So stratifying this a little bit further, the GOG-99 study defined more specifically who was intermediate risk, so stage 1B, 1C, and 2A and 2B cancers. All these women underwent staging and then were treated with or without post-op whole pelvic radiation therapy. They excluded serous and clear cell cancers. And what we found was that it improved progression-free survival with adjuvant radiation therapy, but no statistically significant improvement in overall survival. So the subsequent PORTEC trial looked at women who are high intermediate risk, again defining a little more specifically these high intermediate risk women with a system that's a little more similar to what we use now, i.e. an age stratification, randomized to whole pelvic radiation versus vaginal cuff brachytherapy. And in this study that we found that really all the areas that they looked at were not statistically significant. So disease-free survival and overall survival were the same, as well as the sites of recurrence, whether they be in the vagina, locally in the pelvis, or more distally. So how do we treat these high intermediate risk patients? Well, the GOG-249 trial, which recently did have data reported, was a very complicated trial that took a long time to accrue. And it probably will affect somewhat the interpretation of the data once it's all available. But these were stage 1 to 2A women with endometrial cancer with high intermediate risk factors, and then also included high-risk histologies, serous and clear cell cancers, as well as some stage 2B cancers. So a somewhat heterogeneous group, and they were randomized to whole pelvic radiation therapy versus vaginal cuff brachytherapy plus 3 cycles of carboplatin and Taxol chemotherapy. And this was recently reported in September at the ASTRO meeting, with some findings that I think surprised everybody. Namely, whole pelvic radiation had a lot more utility than people had given it credit for. And whether this is kind of a true finding or whether this is due to the heterogeneous patient population, we're kind of awaiting more data for subgroup analyses. But let me go through what was presented. So whole pelvic radiation versus vaginal cuff brachytherapy plus 3 cycles of chemotherapy, about 300 patients in each arm, and the majority of the patients in both arms completed the prescribed therapy. There was no difference in recurrence-free survival or overall survival. 82% of patients in both arms were recurrence-free at 3 years, and the difference in overall survival was not statistically significant. The incidence of recurrence in the pelvic or periaortic lymph nodes was significantly higher in the patients who got vaginal cuff brachytherapy and chemotherapy, with a significant hazard ratio. The distant recurrence rate was the same in both groups, and the grade 3 toxicity was significantly higher in the patients who'd received chemotherapy. So some provocative early findings. I think a lot of people had moved away from whole pelvic radiation in favor of brachytherapy, with or without chemotherapy, depending on high-risk features. But this certainly brings some new evidence to that discussion. So where to go from here with the high intermediate risk patients still probably will be an area of active debate, but we have more evidence now than we had a year ago. So what do we do for extra-uterine involvement? Well, certainly high-risk factors for recurrence include spread outside the uterus. And you can see the recurrence rate with these factors is significantly higher. So for advanced disease, one of the early studies looking at chemotherapy in these patients was GOG 184, comparing cisplatin and adriamycin with a 3-drug combination of cisplatin, adriamycin, and paclitaxel with a 3-year progression-free survival that was similar. The TAP regimen did become the standard of care until the last few years when the results of the GOG 209 study were published showing a similar efficacy with carboplatin and paclitaxel to the 3-drug combination with significantly less toxicity. And so carboplatin and paclitaxel for the treatment of advanced and primary recurrent metastatic disease has certainly become the standard. There have been some published or some presented data in the last few years from GOG 86P study and the MITO-N2 trial suggesting that adding bevacizumab to the carboplatin Taxol combination may have additional efficacy. These are both phase 2 trials, and so at this point we're awaiting more randomized data, but certainly suggestive that we may be able to improve on that combination. Endocrine therapy is certainly well tolerated with minimal toxicity. The majority of patients who benefit from endocrine therapy are those with low-grade tumors with endometrioid histology. We can confirm somewhat the likelihood of response by testing for estrogen and progesterone receptors, but certainly this is a viable treatment option for patients with recurrent disease. A number of trials of endocrine therapy have been done through the GOG. The one showing the kind of best efficacy was this kind of alternating combination of magestrol acetate with tamoxifen, which kind of is at least the currently accepted standard. So I talked a little bit earlier today about immunotherapy in endometrial cancer, and certainly the availability of pembrolizumab for patients who have MSI-high tumors has changed somewhat the paradigm since the other available agents we have for the treatment of advanced and recurrent metastatic disease in the second-line setting is pretty poor. So we are at this point testing the majority of our patients with recurrent endometrial cancer who have already received a platinum taxane combination for the presence of MSI and treating with pembrolizumab if that's present.